Hey, just gonna give it a few more seconds as people are coming in. Hello, welcome everyone, welcome. Oh, everyone's coming in, welcome. We're just gonna give it another minute and then we will kick this off. Right. Again, welcome. All right. So I am going to kick this off, everybody. So, well, hello and welcome to a webinar called Impact of Post-Diagnosis Weight Change. I am Megan Claire Chase, the Breast Cancer Program Director here at SHARE, and I am also a breast cancer survivor. Now, before the presentation begins, I'd like to tell you a little bit about SHARE. If this is your first time with us, we're a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about our upcoming webinars, support groups, our helplines, please visit our website at sharecancersupport.org. All right, now we have a few housekeeping reminders for you. All participants will be muted during this presentation. Once our fabulous speaker finishes presenting, we'll begin the Q&A discussion. Now, feel free to ask any questions through the Q&A section at the bottom of your screen. And remember that Dr. Malik is unable to give specific medical advice, so please make sure to keep your questions general in nature. We also have closed captioning available, and you can enable this feature by clicking on the live transcript button on the bottom of your screen and selecting the subtitle option. This webinar is being recorded, and we'll share the recording in a few weeks with all of the registrants, and will also be on our website. Are y'all ready? Okay, so now I would like to hand it over to Dr. Malik.
Hi, everyone. Good evening. I am Dr. Manmeet Malik. I am an assistant professor of clinical surgery at Weill Cornell Medicine and the director of the breast center at New York-Presbyterian Queens. I am a general surgeon who has done fellowship training in breast surgical oncology, and that is 100% of my practice. I know I look young, and I hope I look this young forever, but I have been in practice for about 10 years. And I primarily practice in Queens, as I mentioned, and serve a very diverse patient population. And so I'm excited to talk to you today about breast cancer and weight changes pre and post diagnosis. So I'm going to share my screen. Okay. So weight change, obesity, overweight, being underweight are all things that we've been exploring for quite some time, and how that affects a cancer diagnosis. So I'm going to start today with a little bit of an overview of how do you define obesity? What are these words that we use, and how do we come up with these terms and define a patient as obese and not, and the different levels of obesity? So the standard thing that you may encounter when you speak to a primary care physician or any healthcare provider, or even see in the community day to day, is BMI. So BMI stands for body mass index, and that's primarily measured by height and weight, and it's done by gender as well. And those are easy kind of ways to gauge someone's BMI. And then there's different levels, which I'll talk about in the next slide, to determine if a patient or a woman or a man is normal weight, overweight, or obese. And then there's another way we talk about obesity, which is body fat distribution, which is actually a better predictor of health hazards, but something that we don't use as frequently, unfortunately, in the medical world. And body fat distribution, what I mean by that is, where is your fat? Is it in the subcutaneous space, which is the area underneath the skin, which is what we visually see, or visceral, which means organ? So is it fat that's collected and settled around the organ, something that we may not be able to see visually? So BMI has these different categories, which once again is calculated by height and weight. So a normal range is 18.9 to 24.9. And then you can kind of see on the slide how it increases as we go from overweight to class 1 obesity, class 2 serious obesity, and class 3 severe obesity. The problem that we have with BMI is it doesn't take into account this body fat distribution. What percentage of the body is fat versus muscle? And a lot of you have heard that muscle weighs more than fat. So if you're an athletic person, you may weigh just as much as somebody else who actually has more of a body fat composition than a body muscle composition. So I like this little depiction that I have here on the slide, where it shows you that 1 pound of muscle, which is actually smaller in quantity, takes up less space, but it weighs just as much as 1 pound of fat. And this is a great drawing that I found from a New York-based company that developed it for cosmopolitan.com, which shows how 6 women with the same BMI can look so different. So if you look to the left, that person 1 has a little bit more tissue around the abdomen and the buttock area. And then as you move to the right of the screen, where person 6 is located, that person looks pretty fit. They all have the same BMI. Each body is 5'7" and weighs 145 pounds, but it looks so different because it depends on the distribution of the fat. And this is an image from Lancet, which is it's a reputable medical journal, and it shows a metabolic unhealthy individual on the left and a metabolically healthy individual to the right of that image on the left side of the screen. And you can see the metabolically unhealthy patient has more fat around the liver. So that larger orangish structure is the liver. And then these circles, these ovals that are yellow are the fat. And changes in fat distribution can result in less visceral peri-organ fat and more fat that's distributed to the sides of the body, the subcutaneous areas. And that can happen by increase in physical activity, but it'll change the way the body looks. So it's a little bit confusing. You can't just go based on how your body looks. There's so much more internal that we don't visually see that determines if we're a metabolically unhealthy or metabolically healthy person. And the things that, when we look at metabolism, we look at energy intake and we look at energy output. And so when we look at energy intake over here, for all of us, it's food. We take it in with different sugars and fat, and then our genetics and our hormonal status, which we're going to talk a lot about this evening, are going to contribute to how our body processes that energy intake and to make us a metabolically healthy and a metabolically unhealthy individual. But either way, if you're metabolically healthy or unhealthy, the energy expenditure is important, and that's usually by physical activity. So body fat distribution, as I had mentioned, it's a better measure of how healthy we are, but it's something that we don't do that often. And how do we measure those types of things? Waist circumference, waist to hip ratio, and waist to height ratio, and also by different scans. So a lot of you may have heard of a DEXA scan. A DEXA scan is usually performed to evaluate bone density, but it can also be used to evaluate fat distribution in the body. Then, of course, CAT scans can visualize the internal organs and see if there's fat around them, in them, and the subcutaneous fat as well, along with a PET CT. So a PET CT is something that is used a lot of times to look to see if disease and different cancers have spread to other parts of the body. So that incorporates a glucose molecule along with a CAT scan to evaluate different things in the body, one of them being fat. So I'll tell you a quick story. When I have 2 kids, and after my second child, I wanted to get back into physical exercise, but I didn't really know an efficient way to do so. So I started to work out with a trainer who specialized in peripartum fitness. And it was interesting. It was the first time I had experienced someone measuring me. And she kept telling me, don't get on the scale, don't get on the scale, because initially you may see your weight drop, but that may be just how much water retention you have or lack of water retention. And a more accurate way to measure how you're doing and how fit you are, and how much, how the different levels that you're improving is actually by measuring. So she used to measure my waist, my arms, my legs. And it was the first time I'd encountered that. And I was shocked that all of this time being a medical professional, I wasn't even aware that there was different ways to measure how physically fit you are. And it's not just based on BMI. And now we talked about what it is. Now, how common is it? Why is this something that we really need to be talking about? And as you can see from this graph that I found on the CDC website, over time, obesity has been increasing. This is not a surprise to us. You hear a lot about this in the media. We hear a lot about childhood obesity, the negative effects on health with an obese person. And unfortunately, it is on the rise, not just of obesity, but severe obesity as well. And why is this important? Because it affects our bodies. It can cause type 2 diabetes, heart disease, fatty liver, which has all of its subsequent sequela after that, kidney disease, gallstones. And the direct effect that patients will feel is difficulty breathing, asthma, sleep apnea, joint pain, feeling like you just are very heavy on your feet, which can lead to back pain, and then gout as well. And now we're going to get to cancer. So we know that obesity is related to at least 13 different kinds of cancer. You can see the whole list over there, and breast, specifically postmenopausal women, is what we're going to focus on today. So obesity and breast cancer, I'm just going to scratch the surface of this today. This is a very complicated, partially not well understood area of study, but it's come to be something that we have found to be very important in this day and age in how we treat breast cancer. So obesity was first reported to have an impact on breast cancer diagnosis and outcomes in 1976. So this is not something that's been around for that long of a time. And the studies that have come out since then show that obesity is associated with worse outcomes, but we don't really understand why. So obesity, we know, is an established risk factor, as I just discussed in a prior slide, for metabolic syndromes and type 2 diabetes and cardiac events, heart disease, which is actually the main cause of mortality and death in women with early stage breast cancer. The breast cancer itself is not the problem. In most of the reasons why these early stage breast cancer women pass, they just may also have a diagnosis of breast cancer. The reasons for the adverse effects on obesity on breast cancer are very numerous and very complex. So just to get into it a little bit, obesity and its downstream effects. So we know that the food we take in, the nutrition, our obesity, our physical activity, all have effects on how our body processes our cells. So DNA, the makeup of our cells, how that's repaired and broken down, how the cells grow, how our hormones are regulated, how the cells kind of go to different things, like what's going to become a breast cell, what's going to become a heart cell, what's going to become a liver cell. That's called differentiation. Also, the inflammation and our immunity, our immune system. apoptosis, which is cell death, and that needs to be regulated because we need cells to grow, but we need cells to die, and that's involved with the cell cycle. And all of this is part of the pathway that leads to cancer. And this is just to give you a little snippet of some studies that have been done looking at obesity and breast cancer. Once again, this has not been something that's studied for a long time, but there are large studies of, one of them quotes here, 243,000 women involved in these studies, all which then kind of hint towards obesity and breast cancer having a link. So there are biological factors, and those of you who have had breast cancer, are thriving, are surviving, and know people who have been afflicted by this, maybe this will sound familiar, an aromatase inhibitor. And this is where the aromatase inhibitors come into play. So cholesterol. Cholesterol, we've all heard of that. Some of us have high cholesterol. Cholesterol is also something that's related to fat and fat intake. And when that breaks down, it forms something called DHEA. DHEA is then converted to estradiol, which is a form of estrogen, by aromatase in the ovaries and in fatty tissue, adipose tissue. And this is where our aromatase inhibitors come into play, because it blocks the aromatase. So it blocks the peripheral conversion of cholesterol or fat into estrogen. And we know that estrogen can cause increased proliferation of breast cancer cells, especially those breast cancer that feed off of estrogen and have the estrogen receptor positivity on them. And so that is the pathway in which aromatase inhibitors work. And so the excess estrogen production from expansion of the fatty tissue has been proposed as a possible mechanism for the adverse outcome in obese women with breast cancer. And to get into it a little bit more, because it's not as simple as that. When we look at a fat cell, they have these inflammatory markers, and obesity produces inflammation in the adipose tissue. And that then produces these pro-inflammatory mediators such as TNF-alpha and interleukin-6 and interleukin-8 and all of these very technical biological terms and structures that then can, through this very complicated pathway, cause production of cancer cells. And I'm just, on the surface of how complicated this is, and something that we really don't still fully understand. But it's important to show this because it shows the mechanisms of obesity and how that may drive breast cancer. So all of this can have, so there's multiple layers. So we spoke about how obesity can cause breast cancer or may be associated with breast cancer, but it's more than just that. It can have effect on screening, diagnosis, and treatment. So there have been studies that show that there's a correlation between obesity and TNM stage at diagnosis. So TNM stage is tumor size, nodal involvement, and if the disease has spread, metastasis. And studies have shown that there has been an increased lymph node involvement and metastasis on women that are obese with breast cancer. It's unclear whether that's due to diagnostic difficulties. So if you have a large breast and they're trying to image your entire breast in a mammogram machine, sometimes it's hard to get the whole thing in there and to get all the way down to the muscle and to look at the lymph nodes. There also have been studies that show that there is a decreased adherence to mammographic screening in obese patients. There are also increased risks of surgical complication for obese breast cancer patients, increased risk of complication with anesthesia and placing of the breathing tube, increased risk of bleeding complication and surgical site infections. Those women who have a BMI over 30 were noted to have more post-operative breast asymmetry and less matching and less favorable cosmetic results from their breast cancer surgeries with or without reconstruction. And obese women may actually not be candidates for reconstruction because there is data, which I kind of touched on here before with the surgical site infections, that the complication risk may be higher in obese women. And a lot of that is due to comorbidities, because obesity usually comes or may come hand in hand with diabetes. And if diabetes is not well controlled, there is an increased chance of wound complications and surgical complications in general. Lymphedema is something that I want to touch upon briefly. There are known risk factors associated with the development of lymphedema. And there's got to be a lot of education about this, because some patients have the misunderstanding that if they have just even a few lymph nodes removed with a sentinel lymph node biopsy, their risk of lymphedema is high, and that the arm needs to be protected, meaning no blood pressures, IVs, blood draws. That is not accurate. What you want to do to avoid lymphedema is to decrease the chance of infection. And it's correlated with the number of lymph nodes removed during surgery. So if someone has an axillary lymph node dissection and has more than 10 lymph nodes removed, then their chance of getting lymphedema is higher baseline, regardless of if they have obesity or not. But more than saying that, you can't draw blood or you can't take a finger stick from that arm, it's more about avoiding infection. But we know that the use of chemotherapy, radiation therapy, and other comorbid medical conditions, including obesity, increase the risk of lymphedema. And that is theorized to be caused by the pressure of fatty tissue on the very, very delicate, thin lymphatic vessels that are already injured from surgery and radiation and chemotherapy. And now there's the pressure of the fat lobules on them that are going to affect outflow and then swelling of the arm and hand, as depicted in this picture. There could also be barriers to chemotherapy. So obesity is associated with reduced response to therapeutic treatments. And what does that mean? So we have pretty standard regimens and doses of the medications that we give to patients, but there could be some changes based on weight. But a lot of these medications are not dosed based on weight. And if they are, there are limits to the dosages that can be prescribed. And does that theoretically lead to undertreatment in obese patients? We don't know, but it is a possibility. Also, in the adjuvant setting, full doses of chemotherapy are associated with a greater improvement in overall survival. So if we're not really giving a patient a full dose, if it's weight-based, then is that going to affect a patient's survival? And we're not sure about that, once again. And as I touched upon before, obese patients do require higher doses of chemotherapy to achieve these therapeutic levels, which are given, but to a limit. Endocrine therapy, so kind of what we touched about before with the aromatase inhibitors. Once again, it is a fixed dose regardless of weight or body surface area. And there have been some studies, there's this one that I want to highlight, which is the Austrian breast and colorectal cancer study group, which looked at 12 trials. So it included quite a few patients with early stage breast cancer treated with a hormone. It decreases the ovarian function, and looked at to see, would they benefit if they received tamoxifen or anastrozole. And what they saw was that overweight women assigned to anastrozole had a 60% increased risk of disease recurrence and death compared to their normal weight survivors. So even though 1,800 patients seems like a large study, it's really not. But it kind of gives you an idea that these types of things need to be explored a little bit more. And the study also looked at the benefits of adjuvant chemotherapy or endocrine therapy were significantly less in the obese population, and they were independent of tumor size, nodal status, known prognostic factors, including hormone receptor status. So this is something that we need to explore a little bit more. So where do we go from here? And I want to be clear, being overweight does not directly cause breast cancer. But we're kind of getting some more data and some more information that there may be some connection. But then again, not everyone who's overweight or obese is getting breast cancer. And not everyone that's normal weight or underweight is not getting breast cancer. So it's a much more complicated system than we understand. But when we start to see links, we should be proactive about trying to identify those interactions and what can we do to further help our patients with the information that we're gathering. So there's a lot that we do not know about breast cancer. We do not know what causes breast cancer, and only 5 to 10% of breast cancers are hereditary, which means that the other, 95% are just sporadic. We don't know what causes them, but we're starting to get a little bit more information with all the research that's been going on in the breast cancer world, that there are some things that we think may help if we can control them. So we know we need to do something about it. And so I wrote this paper with my colleagues last year, kind of addressing this and the need to mitigate breast cancer disparities by addressing the obesity epidemic. This is not talked about enough. And as the incidence and the prevalence of obesity is increasing over time, this is going to be something that we need to address more and more. And I speak to a lot of patients who tell me, there's so much during my cancer treatment that I could not control. I couldn't control that this happened to me. I couldn't control what treatments I needed and where I needed to be when to receive them. So what can I do to help decrease the chance of this coming back? And this is what we do know. We do know that 150 minutes of physical activity a week may reduce breast cancer recurrence. So I'm not talking about now the cause of breast cancer, because we touched on that already. This is what can we do to decrease the chance of the cancer coming back. And this has been studied and shown to be effective. So I like to break it down for my patients by saying 30 minutes of exercise 5 days a week. Everyone can do something for 30 minutes. You just got to make it part of your routine. And physical activity means usually something cardiovascular, something that's going to get your heart rate up and get you sweating, whether that's swimming, biking, jogging. You don't need to join a gym, just something to get your heart rate up and get you sweating for 30 minutes, 5 days a week. And I've been reading some papers of how long does it take to form a habit? It could be anywhere from 3 weeks to 3 months, depending on how frequently you incorporate it into your lifestyle. So I think that's important to know, because this is not something that's going to happen overnight. It's going to be hard for the first 3 weeks to 3 months until it becomes part of your normal routine, but then your body's going to crave it. The endorphins, the changes that you start to see, it's going to be something that you want to do just to make yourself feel better. And you know what? It'll decrease your breast cancer recurrence risk. So steps we can take, a healthy, balanced lifestyle. I know I'm going to get a lot of questions about, I'm postmenopausal, my estrogen's being I don't have as much, and it's so much easier to gain weight and so much harder to lose weight. I get it all. But try different things. It's a lifestyle change. It's about developing a healthy, balanced lifestyle. And that is by trying to tackle 3 different things: diet, exercise, and mental health. Because at the end of the day, it's all about hormonal homeostasis. And think about those of you who have had breast cancer, about how your hormones were all out of whack. You're going through the diagnosis, you're stressed. That is not good for your hormones. Then you're getting your treatment, your hormones are being manipulated. And now you're coming off of your treatment and everything is kind of evening out, but still kind of going haywire. And life in general is going to affect our hormonal homeostasis. And so for each person, it's going to be different. There is no recipe or protocol that's going to work for all. So number one, you have to talk to your healthcare provider, because you may have something underlying in addition to everything that we spoke about today that could prevent you from maintaining and achieving a healthy body weight, whether that be underlying insulin resistance, Do you have diabetes? Is it something that can be controlled with diet? Is it something that needs medications? That's all something that needs to be evaluated by your primary care physician. Are there other, is your thyroid off balance? That's affecting your hormones and your ability to maintain a healthy body weight. And healthy body weight could be different for different people. As I touched upon before, is it visceral fat? Is it subcutaneous fat? Where is this living in your body? Don't just go based on the scale. And then once you kind of have ruled out all of those other things, now you can focus on lifestyle changes. So, I do intermittent fasting. That works for me. That doesn't work for all. Some people need to change it up in terms of trying something for a couple of months and then kicking your body into overdrive by switching to something else. Exercise programs doesn't mean you need to join a gym, as I mentioned before, just active. If you see a staircase or an escalator, try taking the staircase, but you don't want to get winded. So baby steps. Mental health, that's going to affect how your hormones are. And we live in a day and age where life is crazy. There's a lot going on. And how do you bring yourself to a state where you feel calm and you feel controlled, and you feel like your hormones are in balance? So there's a lot that we know may contribute to breast cancer recurrence. We don't know it all, but I think that these are some of the steps we can take to help ensure a healthy, balanced lifestyle, decrease our breast cancer risk of recurrence, and also our overall health. And remember, these types of things are not only, it has multiple health benefits. Someone's diabetes may be better controlled with weight loss and a healthy body weight, cholesterol, high blood pressure, multiple other different types of cancer. So you have to find what works for you, but you got to start from the base of making sure that you're seeing your primary care physician. And another thing that I'm not going to talk too much about today, but is another option that can be thrown in there, is bariatric surgery. It's not for everybody. And it's not that you're going to walk into a bariatric surgeon's office and they're going to offer you weight loss surgery. It's a process. It's at least 6 months of, seeing the different specialists, the heart doctor, the lung doctor, the nutritionist, the psychiatrist, to make sure that all of these things have been addressed prior to going to weight loss surgery. But I've had patients who have come and told me, I've tried so much and it's just not working. That is another avenue that one can explore. And I think that's it, because I would love to have a nice, healthy discussion about everything that we discussed today. But thank you for having me this evening.
Well, thank you so much, Dr. Malik. That was a lot of information. And we got a lot of questions submitted with registration, but I do want to go to some that we've received live first, and then we'll get into it. Someone on our Facebook has asked this question: will there be some information about the challenges of too much weight loss? This, when you're having difficulty keeping your weight up while you're in treatment, what can you do? What are some things that can be done?
Excellent question. So this is something that I usually do not start to discuss with my patients until they're in their survivorship period, because there is so much going on during treatment. And yes, we want patients to maintain a healthy body weight, because those of you that have gone through chemotherapy know that chemotherapy not only kills the cancer cells, but it also kills the good cells. So you need the nutrition, you need the protein, you need, you need the calories to be able to help your body regrow your good cells so that you can then be healthy enough to undergo your next dose of treatment. So this is usually something that I discuss with patients in their survivorship. And when patients are mentally in the right space to be like, okay, you know what, I've done what I've been told to do. I'm tired of being told. What can I take into my own hands to do this for myself? And that's usually when I introduce it, because 100% we want patients to be eating calories, healthy calories, during treatment.
Oh, so as I was listening to you and I was looking at a lot of the questions, a lot of it, and you touched on this, is how difficult it is to lose weight while on AIs, while we have these estrogen blockers. Like, can you maybe explain a little bit of what is happening in the body that just seems to make it so easy to gain weight when you are on AIs, or for those, like even myself, I'm not able to take any AIs due to really bad side effects. What is going on in our bodies? We just don't seem to understand this new change.
So it's complicated, but if you remember one of the slides that I showed where it was the pathway of cholesterol to estrogen. So aromatase inhibitors is preventing the breakdown of cholesterol to its substrates, right? Testosterone and estrogen. So if it's not breaking it down, it's hanging out at cholesterol. Okay. So that's part of it. Our bodies, the estrogen helps break down the fat. I mean, the aromatase helps break down the fat, because we don't want the breakdown product, which is estrogen, for a woman who has estrogen receptor positive breast cancer. So if you're not breaking it down, there's more of it around. And so it's harder to get rid of. That is just one part of the very complicated schema of why postmenopausal women in general have a hard time losing weight, because they have less estrogen, and that whole pathway is all out of whack. And then when you're on an AI, we're disrupting it to get to one point, but then you're leaving all of this cholesterol behind.
Yeah, it's frustrating, right? It seems that for some of the medications out there, and I know you are not able to give medical advice, but just what I'm seeing coming in as far as like the questions of like, is weight gain a side effect of tamoxifen, or one of the other AIs? Like, how do you handle that when certain medications can cause a weight gain, on top of for some being either they were diagnosed at postmenopause or they were surgically moved into menopause?
Yeah, and remember, tamoxifen does the same thing. It's blocking estrogen. It's just doing it from a different pathway, a different mechanism. But the end game is the same, to decrease the amount of estrogen in the body. And that's why I think it's so important to focus on these other things, because you need it for treatment, right? We're a lot of, unfortunately, in medicine, it's side effects, right? You give one thing to make something better, and then you're causing something else. But that's why we have to find other ways, because it is what it is, right? It's the mechanism of action of the medication. It's what our bodies are doing when we're in a postmenopausal state. But there are other ways to combat the increase in weight. And that is with the physical activity, because it's about energy in and it's energy out. And the best way energy out is by physical activity.
When we hear that, sometimes that can feel really overwhelming, because our bodies, we're also dealing with this added fatigue, post-treatment, or for any of those who are, still in treatment, there is that layer of fatigue. And it's like, how do you push through that? And then, of course, you're like, gosh, I want to move, but now, you know what? I'm just going to eat because I'm upset. Like, why is this happening? What do you say to patients who are struggling with that push-pull of, I do want to move, but it hurts to move. I know I should eat better, but it's hard because I'm, emotionally and mentally going through so much.
Right. The first thing I say is, you're not alone. Okay. This is extremely common. And that's why I think it's so important to spread awareness about this, because a lot of women feel alone. They say like, oh, I'm going through this and my sister doesn't have this and she looks fit and healthy. Well, your sister didn't have breast cancer, but you know what? 1 in every 8 women in the United States gets breast cancer. So you are not alone. That's number one. And, that's why you have to be in the right mind frame to kind of start these. You have to want to do it for yourself. And because it can be overwhelming. So if you're not mentally ready, emotionally ready, don't try it, because you don't want to set yourself up for failure. So you have to be in the mental, emotional space to be able to want to try to make this change. And whether that's talking to other people who have done it, support groups, avenues like that, to kind of get a group together to be like, you know what, let's try this together, and to reinforce the fact that, we're not alone. But it takes time to form a habit. So it's not going to be easy. So when you feel like you can do it, that's the time you should try. But you should also know that you're going to have to set aside time. You're going to have to really make sure that you're doing the self-care and setting your time aside to do so, because it's not easy and it takes time, and it's a lot of trial and error, and you'll slip and you'll fall. Whereas, my husband was like, I'm on a roll and I'm getting up every morning to do yoga. That lasted for 3 days, but we're going to get back on it, right? Because he knows that makes him feel better, for example. And once you start to do something that works for you, because once again, to each their own, and it's not going to be the same cookie cutter formula for everybody. When you find something that makes you feel good and that you start to see results with, you're going to want to do it more, but you're going to have to push a little bit for the first 3 weeks to 3 months until it becomes something that your body craves and becomes a habit.
So let's talk about sleep. I see a lot of questions talking about, like, how can we lose when we're dealing with, low sleep or broken sleep. And that doesn't mean that you have sleep apnea or anything, but like you're just really struggling with your sleep.
Mhm.
And I know that we constantly hear, hey, one of the major things you need to do in order to lose weight is to also have good sleep, so everything can like renew and regenerate. But when you're dealing with so much ongoing fatigue, are there meds or things that we can do to help?
Yeah. Great topic to discuss. Sleep is really important for hormonal balance. And it all goes back to my last slide about hormonal homeostasis. Sleep is a big part of that. So yes, there are medications that patients can discuss with their healthcare providers. But for some reason, and I think that medications for a short period of time are fine. A lot of people are afraid. I've had patients being like, I'm afraid of getting addicted. I don't want to take pain medications after surgery. I don't want to take sleep aids to help me fall asleep because I'm afraid I'm going to get addicted. If you're doing it under the supervision of a physician, it's going to be done safely. And so don't try to be a hero. I think it's take the help if the help is available, and if it's something that your doctor feels may be beneficial to you. That's number one. Number two is that if you don't want to go the medication route, lifestyle changes. Do you feel yourself drinking something with caffeine after 2 p.m.? You might want to try to cut that out, because it's a vicious cycle. So if you're waking up tired and you have your cup of coffee, and then you have your food intake, and then you feel like by mid-afternoon you're having a little bit of a crash because your glucose levels are going down, then you feel like you need something with caffeine, then your caffeine spikes at 2, 3, 4 o'clock in the afternoon, you're going to have trouble falling asleep. So try to make those little changes where be a little bit more conscious of, when are you consuming caffeine? When are you consuming things that are going to prevent you from falling asleep easily? Screens. There's a lot of data out there about screens, and I'm guilty of it myself. I like to scroll through my email before I go to bed, and I don't know why the world would be blowing up in my industry at 9 o'clock at night, but we have this need to be connected, whether that be with our emails, text messages, or social media. People decompress like that by just kind of scrolling, but that blue light's not good. So some people wear blue light glasses. If you enjoy kind of having that routine and that ritual before you go to bed, that's okay. Just try to maybe put on a pair of blue light glasses, or kind of restrict it that the last 30, 45, optimally an hour before you go to bed, you're not having that stimulation. Having a nice dark room. Blackout shades, eye shields have been shown to help with better sleep. Making sure that the room is cool. It's sometimes uncomfortable to fall asleep in a very cold room, but studies show that sleeping actually at like 67 degrees is the optimal sleeping temperature. Things like that can be tried. And I have to say, from personal experience, physical activity, and I keep going back to it, the endorphins that your body releases, it helps with a better night's sleep. And it's one of those things that once you try it, you're like, oh, this actually makes me feel better. I don't feel great during the workout, but afterwards, I feel that like release of the stress from the day, or if you work out in the morning or whatever it may be, and then your body's able to relax and get a better night's sleep.
So we have this this question, and I am really like resonating with it. This person, they are 50, probably premenopausal. They finished chemo, everything, surgeries for triple negative, and they're trying to, maintain their weight, right? But it's really difficult. This person suffers from chemo-induced peripheral neuropathy. I have that too. Really, actually, really pretty debilitating in my feet. Even to, kneel, to walk, even a couple of steps can be painful. So what do you recommend? Because we're hearing, all this physical activity, but for a lot of us, and I'm including myself in that group of where it's painful or we can't even feel our feet.
Yeah. It's tough. That is tough. When you have these underlying symptoms that are going to prevent you from doing physical activity, there are lots of different things that can be done. People have tried acupressure, acupuncture. I know it's not easily available for a lot of people, but if it is, that's something that you can try to deal with the peripheral neuropathy. The problem is once it settles in, it's tough to kind of to help at that point. But try different things as you get the blood flowing. It might help. If walking doesn't suit your lifestyle, then maybe biking, maybe swimming, maybe just even walking down the block a little bit. It's not a one size fits all, and everyone kind of has to take these little things that their body feels into consideration. Some patients have, really bad joint pain from the aromatase inhibitors, and it hurts to move. But when I've had discussions with those patients, and once again, not the same for everybody, they say they feel better when they start moving. Like it's really bad when they first wake up and they're stiff, but once their body gets warm and they start moving around a little bit, it's a little bit more tolerable. It's about blood flow, and my hands and my toes are always very cold, and so I try to keep moving and wear gloves and things that make me more comfortable to be able to do my activities. And so everyone kind of has to take into consideration about what makes them feel better to be able to get moving.
That's true. It's almost like you have to trick your mind, because you're like, this hurts, I need to stop doing it. But knowing that, okay, maybe if we're telling ourselves this is just to get you warm, like it's going to hurt in the beginning, but I think sometimes it can be difficult for those of us that do have like these different pains to realize, wait, I'm not hurting myself. Like, though I'm feeling this, I'm not actually hurting myself. I know once I just get through maybe this first 5 to 10 minutes to just warm up will help. Right?
Yeah, and it's baby steps, right?
Yeah.
You can't expect your body to do what it did pre-treatment. And so it's working out, because you do want to be safe and you don't want to hurt yourself. Like if you really don't have good sensation on your toes and you're putting on athletic shoes for the first time in a long time, and you're like, does this hurt because of my neuropathy, or is it hurt because like my shoes don't fit right and they're rubbing against the inside of my shoe, right? So you do want to do things safely, and you have to listen to your own body. And so it's gradual. it's really gradual, and it's taking those small steps every day, maybe increasing it by a minute. All of that makes a difference, to get yourself to a place where you're like, I think I can do this. I feel like it's making a difference. I'm doing this safely. That, it's not a comparison. It's not a marathon. I always get a little worried, like I'm weary about these apps that, you can see what you're doing in comparison to somebody else in regards to physical fitness. You got to be careful with that. It's after treatment, body doesn't work the same way. And that's okay, right? Because we accomplished one goal, and now we got to start to accomplish another goal. But we got to work our way towards our end goal. We can't it's not a marathon.
Well, and speaking of apps, we actually had a lot of questions come in about, like Noom or Weight Watchers, or, are those do you recommend that we look into apps like that to maybe keep us accountable of what we're eating? Or what is your opinion? Do you think that actually causes more harm? Or what do you think?
I don't know enough about Noom to comment on that. Weight Watchers has been around a long time, and it really has this nice community to it. And there are different programs other than Weight Watchers, but that's just an example. I think it's good about helping you kind of have an idea of how much you're consuming, and calorie counting, and points, and why does one thing have more points than another thing. And I think it just brings awareness to it, because sometimes we think we're eating well and we're eating healthy, but then when you look at the point distribution, you're just like, oh wow, like I thought I was doing such a good job, and wait a second, that is a fruit, but that fruit has so many points, right, associated with it. So I think it's fine to be a little, if it allows a person to become a little bit more aware about what they're eating and how they're eating. At the end of the day, I'm a firm believer in whatever you do, it has to be sustainable. So some of these things are fads. You start with it. I had a patient who was like, I'm only going to eat vegetables for a week, and then I'm only going to eat fruit for a week, and then I'm only going to eat this. And I was just like, but what happens when you start to eat normally again, right? Like your body is like completely out of whack and can't process food like it normally did. And you're just going to gain all the weight back. So it's lifestyle changes, smaller portion sizes. And at the end of the day, we got to live life. If I have a sweet tooth, if you want a cookie at the end of the day, have your cookie. But there has to be balance. Like don't eat cookies all day long if you want to have your one treat in the afternoon. Portion control, looking at your whole day. What are you consuming? Whether that's something that Weight Watchers that helps you do it, or another type of app, or just kind of writing it down and do calorie counting, just to be more aware of what we're putting in our bodies and how we're putting it in our bodies. But still giving yourself the leeway and the ability to have things that you enjoy. Alcohol is one of those big things that comes up all the time of like, is alcohol good? Well, I'm reading that red wine's good for the heart, but then I'm reading that alcohol's bad for cancer. So what is it, right? It's everything in moderation. But studies have been showing that alcohol intake, even 4 glasses of wine a week, is like a pack of cigarettes. And we all know that cigarettes are bad. And so there is a lot of this stuff that keeps coming up as we learn more and more about the products that we consume on a daily basis. But if you like a glass of wine, have your glass of wine, but maybe limit it to a Friday night, or if you're going out to dinner and you want to do it on a Saturday night, plan your weeks. Be conscious of, you know what, I know I have this meeting, or I know I'm going to be going out with some girlfriends, or have a family gathering, and I'm going to be consuming X, Y, and Z. Prepare yourself for that. Be like, okay, I'm going to enjoy myself on this day within limits, moderation, but I'm going to allow myself to do that. And I'm going to just watch what I eat before and after for a couple of days. It's all about balance.
So what do you think about, I know I've read in the past, like Mediterranean eating is the way to go, or all plant-based is the way to go. We've got some questions about that. Like, what are your thoughts on, going all plant-based? Or some of us have talked with others and they're like, yeah, it's just all raw. Like, I'm gonna go vegan, or, I think we hear so many different things online, and we're being told different things of like what you should eat, and what's the best type of way to eat. And I don't like to use the word diet. It's really about like that, as you were saying, that healthy lifestyle,
Mhm.
but it can feel really confusing, and sometimes feeling kind of pressure of like, well, maybe I should just go totally plant-based, and you're doing something that's very different from how you were eating before.
Yeah, you have to be careful with it because there are people who go, like, for example, fully plant-based, but then you're eating these meat burgers, right? That have all of this stuff in it. And we don't even know what half of that stuff is, right? And so it really it has to be more thoughtful than that. I think that, you do what feels good for your body, whether that be maybe less meat and more vegetables, or, cutting out a little bit of dairy and only having it with certain things. I don't, I think it's too drastic to swing one way or the other too fast. Because then you kind of limit yourself, and now, like, okay, well, I told myself I'm going to be plant-based. Well, what does that mean to you? Does that mean that you're going to eat raw vegetables, which is not easy? And also, are you going to eat organic vegetables, which can be expensive? And how are you going to create that balance for yourself? Because I don't think it's healthy just to eat the frozen veggie burgers all the time, which are easy, but they have a lot of fillers. So you have to kind of find something that works for your lifestyle, and that when you try it, it makes you feel good, not just because you're putting yourself in a box of like, well, this is what I said I'm going to be, so I'm going to have to be it. I think the Mediterranean diets are great. It's quite a healthy diet of, fish, fruit, vegetables, whole grains. But once again, it's not a one size fits all, and you have to really see what your body needs. Like, sometimes I'm like, I just feel like I need to have whatever.
Right.
And if your body's craving it, you might just need it. And then that gets rid of the craving, and then you're good, whether that be something that's a little bit, not so healthy for you, or something that that you probably shouldn't be eating around this time of day, or but it's what you need. Like, you really have to listen to your body.
So true. I know we're getting close to time, so I think we'll ask about two more questions. I'm seeing a lot of questions about Ozempic and
Mhm.
Wegovy and those types of medications. I know Ozempic particularly is really for those that are diabetic, but it's also known for weight loss. And now people that really need it, as diabetics, are having a hard time getting it. What do you think about those particular weight loss medications?
I'm a little concerned about them. They weren't made for that intent. As you said, Ozempic was made as a diabetic medication. And I don't think it's been studied enough. Like, it was one of those things that came about from my understanding. And once again, this is not my area of expertise, but that it was noted as a side effect of the medication when it was being prescribed for diabetic patients. But hindsight's, there's a lot of bias that goes into these things. And so if it's not studied for its initial intent, we have to take it with a grain of salt. And there's all of this information that's coming out about the side effects of Ozempic and Wegovy and these other medications. So I think we have to be a little bit careful, and definitely don't take it unless it's prescribed by your healthcare provider, and monitored, because there are some things that need to be monitored when patients are on these medications. So you just can't take, your cousin's Ozempic that's in the medicine cabinet. It really does need to be monitored.
Well, Dr. Malik, You have been amazing, and we still had more questions. So everyone, if you still have other questions, please feel free to email us. We'll make sure that we get those to Dr. Malik. But we just want to thank you so much for taking the time from driving in the rain to be here with us tonight. And I want to thank all of our participants for submitting questions and being engaged. Just know that the slides and the recording of this presentation will be available on our website on Share Cancer Support in about 1 to 2 weeks. And also make sure to check out Share's website for upcoming educational programs and support groups. And don't forget, follow us on social media as well. And once we end this awesome webinar, please take a moment to fill out the survey. The survey will show up in the browser as soon as it ends. And then we'll also have the link sent in our follow-up email. And please know that all surveys are anonymous. So again, Dr. Malik, do you have any final words before we end tonight?
Just thank you for the opportunity to speak to this audience. And, obviously I'm a big proponent of physical activity. So get what you can get. It's not a one size fits all. Do what works for you and your body. And I hope to see a nice generation of healthy individuals.
Thank you so much. And thank you everyone for joining us. Good night.
Good night.